Hello, everyone, and welcome to the TMA Ask the Expert podcast series. Today's session is entitled Understanding Neuromyelitis Optica, NMO-101. My name is Roberta Pesci, and I am the Research and Project Manager at the Transverse Myelitis Association. We are a nonprofit focused on support, education, and research of rare neuroimmune diseases. You can learn more about us on our website at myelitis.org. Sam Hughes from the University of Texas Southwestern Medical Center, TM and NMO Center, will be moderating our podcast today. A few housekeeping pieces before we start. This podcast is being recorded and will be made available on the TMA website at myelitis.org, and it can also be downloaded via iTunes. During the call, if you have any additional questions, please send them to us via our Facebook page at facebook.com/myelitis.
Great. Thanks, Roberta. The 2015 TMA Ask the Expert podcast series is made possible through the generous support of Chugai Pharmaceutical Company. Chugai Pharmaceuticals is conducting clinical studies to create original and innovative drugs, both in the United States and overseas, to address unmet medical needs in neurological disorders where the level of pharmaceutical contribution and satisfaction concerning patient treatment remains low. We are excited to be joined by Drs. Brian Weinschenker and Sean Pittock as experts on today's podcast. Dr. Weinschenker is a professor of neurology at the Mayo Clinic in Rochester, Minnesota. He has developed diagnostic criteria and characterized the natural history of neuromyelitis optica. Along with Dr. Vanda Lennon, he is evaluating the clinical significance of the antibody biomarker NMO-IgG, which is highly specific and moderately sensitive for NMO, along with other restricted types of inflammatory demyelination, including longitudinally extensive transverse myelitis and recurrent optic neuritis. Dr. Pittock is a professor of neurology and director of the Neuroimmunology Laboratory at the Mayo Clinic. He has played a central role in the Mayo Clinic studies of the first serological marker for a demyelinating disorder of the human central nervous system, the NMO-IgG. Furthermore, Dr. Pittock's clinical, imaging, and serological studies are providing the foundation for future investigation of the basic immunological mechanisms that cause NMO. He is also the principal investigator of an open-label trial of eculizumab in NMO. So to get us started today, I wanted to have us broach the subject up front. With neuromyelitis optica, it has been called a number of things over the years, and the criteria for diagnosis has changed. It's been called Devick's disease, NMO. Now we're talking about spectrum disorders, including longitudinally extensive transverse myelitis and recurrent TMs. And I was just hoping that starting out with Dr. Weinschenker, if you could kind of give us an overview of where the NMO landscape is at this point and where we're at in terms of the actual definition of NMO spectrum disorder.
Well, thank you, Sam. Yes, as you say, the concept of neuromyelitis optica has been around for quite a long time, but it really wasn't clearly differentiated from multiple sclerosis. In fact, conventional thinking was that patients with neuromyelitis optica had a single event of myelitis and almost simultaneously bilateral optic neuritis, and unless they had those exactly in that way, they didn't have this condition. But in the 1990s, people thinking more broadly and recognizing that MS was not necessarily a single condition and that every condition where there were relapses didn't necessarily mean that the patient had multiple sclerosis, put together criteria. We actually did that for the first time in 1999, that were able to define a group of patients that seemed to have a different disorder than multiple sclerosis. But I think things really changed with the discovery of the antibody biomarker that you mentioned, which are antibodies to aquaporin-4 antibodies, to aquaporin-4 proteins, which is a water channel in the brain. And patients who had this condition could be clearly differentiated from patients with multiple sclerosis. They had a different clinical course, different prognosis, and in fact the treatments that we used to prevent attacks were different. And with that blood test, we've been able to now recognize that some patients who had symptoms that we never previously recognized were associated with neuromyelitis optica, especially intractable vomiting and hiccup, which can occur in 20% of patients with neuromyelitis optica at the beginning, could be part of this syndrome. So we now are recognizing a much broader spectrum of conditions, but it's still one that's most characterized by recurrent optic neuritis and myelitis in most patients.
Thank you for that. I think that was a pretty good overview of where we're at right now. Dr. Pittock, do you have anything to add, maybe specifically about the NMO antibody?
No, I agree with what Brian has said. I think in respect to the NMO antibody, I think the main thing is that the assays that are used to detect the antibody have improved over the years since 2004. And so now our assays are, at least in patients that would have fulfilled, say, 1999 criteria or 2006 criteria of the Wingertuck criteria, if you exclude the antibody, you're talking about, sensitivities now of about somewhere between 70 and 80% with very good specificities. So I think we're certainly improving the assays for detection and diagnosis.
Yeah. There were a number of questions that came from the community, specifically about the antibody, and I think it's a great opportunity since you, Dr. Pittock, are here on the call to maybe answer a few questions. There was one in particular to your point about the assay getting more sensitive and more specific. The question is, I heard that the NMO antibody test has significantly improved in its accuracy over the years. If a test 5 or more years ago was negative, but other symptoms show that NMO is a possibility, should I be tested again?
So that's a very reasonable question, and the answer is yes. You remember that the original assay that was used for detection of antibodies was what we call an indirect immunofluorescence assay. That's basically where you look at the binding of the patient's antibody to mouse brain tissue. And that assay is about 50% sensitive. That means that if you have the disease, you're going to be negative for the antibody in 50% of the time. So through the years, there's been the development of different assays. For example, after that, we then introduced an immunoprecipitation assay, and that assay had problems with specificity. More recently, there's been an ELISA assay, which has increased the sensitivity from about 50% to about 60 to 65%. But there's been some concern regarding specificity of that assay. In other words, that sometimes patients that don't have the disease might be positive. And that led into a number of studies that have led to the development of what we call now cell-based assays. These are assays where you take a cell that does not express the water channel, and you actually transfect in the gene for the water channel. So in other words, you now make that cell express the water channel, and then you look to see if the patient has antibodies that bind to that target compared with the cells without the transfection. And those cell-based assays have now resulted in sensitivities, in other words, the ability to detect the antibody in the disease of about 70 to 75%. And now with even further advancements using computers technology to actually detect the differences, we're now at about 80%. So you can imagine that if now we have a situation where 20% of people with NMO are negative for the antibody, compared with 10 years ago where 50% of people would have been negative for the antibody, and that's purely based upon the ability or the detection method. It is very reasonable for a patient that was negative on one assay that has symptoms and signs that are suggestive or typical of the disease to be retested with the more sensitive assays.
So that's made a huge difference in the diagnosis of NMO and NMO spectrum disorders recently. Dr. Weinschenker, there's a question: is it routine for all patients with an inflammatory attack in the brain or spinal cord to be tested for NMO antibodies?
Well, that's a good question, but a difficult one to answer. And we certainly don't want to miss a diagnosis of neuromyelitis optica, and as Dr. Pittock has told us, our tests are pretty good with very high specificity, but it partly depends on the context in which the testing is done. So that is, if you have a patient who has recurrent myelitis, where there's a pretty good chance they may have neuromyelitis optica, detecting the aquaporin 4 antibodies by the cell-based assay that Dr. Pittock referred to, I think would be very helpful. And in that context, it's very likely that the patient has neuromyelitis optica. But if their clinical features, even though we think it's an inflammatory syndrome in the central nervous system, are not typical, and we're testing this blood test in a less likely to be positive situation, getting a positive result, I think, should be viewed with a lot of caution. Dr. Pittock actually collaborated with a group at Kaiser Permanente and looked at a couple of different tests. And at least for one of the tests that he referred to, the ELISA test, which when they tested a group of patients that were diagnosed with MS, and it did include a couple of patients who probably had neuromyelitis optica, they decided on clinical grounds. But when they just ran that test on everybody, twice as commonly as it was true positive, it was false positive. So I think the most important thing is that doctors educate themselves as to the new spectrum of neuromyelitis optica, recognize brain conditions that might be really suggestive of neuromyelitis optica, and in situations where there's even a reasonable chance that neuromyelitis optica is the correct diagnosis, that this test be done. However, I think it's perhaps not as reasonable to say that every single person who is suspected of having MS should have this test, because ultimately, I think you've got to put together the clinical features and the blood test results to make this diagnosis, and not make it strictly based on the blood test.
It sounds like it's more of an art than a science, like most of diagnostics is.
Well, hopefully more of a science, but there is a bit of art in there, yes.
So there was another question. Dr. Pittock, maybe you can help us out with this one. Is it possible to have a positive NMO antibody test but never experience subsequent attacks after the initial event, assuming that there's no long-term immunosuppressant being taken?
Well, in science and medicine, there's always possibility. But the likelihood is that that would not occur, at least in my experience. And I think really Brian has actually done some of the original work, where what Brian showed was that if you had a single episode of a long lesion in your spinal cord, and you tested patients, and if you divided the patients into those that had the aquaporin 4 antibody and those that did not, the patients that had the aquaporin 4 antibody were at a high risk of developing another clinical event, whether it be another transverse myelitis or the development of an optic neuritis and thus NMO in the year following. Whereas the patients that were negative had a much lower likelihood of developing another event. So generally we know that the aquaporin 4 antibody in the setting of, say, a single event is predictive of another attack. In other words, it's predictive of a relapsing course. Now, if you look at patients generally, what we know is that if, at least in some of the studies that we've done here, is that about 1 in 10 patients will have about 10 years between their first attack and their second attack. So you could argue that for that individual patient, you could potentially hold off on using immunosuppressant medications. But remember, 9 of the 10 patients will have an attack, and most of the patients will have an attack within 1 to 2 years. And the problem is we don't know, we cannot predict which patient is going to have a short interval between their first and their second attack, and which patient is going to have a long interval. And so therefore, it's my approach, and I think the approach of most physicians that treat NMO, that if you have an attack that's clinically NMO or NMO, typical of NMO, and your aquaporin 4 antibody positive, that you should go on immunosuppressant medication with the objective of stopping that second attack or stopping further attacks, and therefore preventing disability.
Yes, that was In your answer there, you answered another one of the questions about what's the average time frame between attacks. And I think it just goes to show that every patient is different, and it's hard to tell at this point in our understanding of the disease process.
Yeah. So what we're doing a study at the moment, a collaboration with Jackie Pallas at Oxford and Anna Jacob at Liverpool, where what we've done is we're doing a mathematical modeling study looking at attacks. So what we've done is we have 500 patients with NMO, and we have documented the date of every single attack that they've ever had. And we're trying to get at exactly that question. In other words, what is the timeline between your first and second attack, your second and third attack? Do attacks occur in clusters? If you have a lot of attacks initially, are you more likely to have frequent attacks? So all of those questions are somewhat unanswered. We know from smaller studies, these are generally center-specific studies of reasonably small numbers of patients that attacks can tend to occur, within 1 to 2 years. But we need more research and more work in that area.
Mm-hmm. There was another question that came up. I think, Dr. Weinschenker, you might be able to help out with this one. I was diagnosed with NMO, but my optic nerve was has not been affected yet. Having this diagnosis, does it mean that without long-term treatment, my optic nerve or vision will eventually be affected?
Well, it certainly doesn't mean that this will happen, but any patient who is diagnosed with NMO and has this antibody is at risk of optic neuritis. Some of the recent studies that have been reported on the clinical course of neuromyelitis optica suggest that people who are older, who have this disease, that is, say, 50 or older, are more likely to have myelitis, whereas younger patients tend to more commonly have optic neuritis. We'll certainly see occasional patients with this condition will have 7 or 8 episodes of myelitis. They've never had an episode of optic neuritis. But I would say that virtually every patient who has this condition is at risk of either myelitis or optic neuritis. And after a period of time, there's a fairly high percentage of patients who may also get brainstem or other brain lesions as well.
Speaking of the brain lesions, there was a specific question about that. So the effects of spinal and optic nerve attacks are more obvious than brain involvement. But what damage is suffered from acute brain lesions and inflammation due to NMO, and what permanent damage can be seen? Maybe Dr. Weinschenker, you can elaborate on that.
Yes, and it is variable. We will see some patients where they have a brain MRI scan and we'll pick up a brain lesion. Some of them even very characteristic for NMO. For example, if you have a brain lesion in the hypothalamus and nowhere else, that we've learned that that's pretty characteristic of NMO. And some patients will have no symptoms that we can tell that they either have or have ever had that could be attributed to that lesion. But some of the symptoms that may occur could include things like sleepiness and narcolepsy, which can occur. Patients will experience problems with eating, for example, severe loss of appetite, possibly even pathologic eating disorder where there's overeating. So those are symptoms of hypothalamus dysfunction. But some of the brain lesions that we see, for example, the most common one we see is one that causes vomiting and hiccups. Practically always this is self-limited. It may go on for weeks or even months in some patients, but practically always this does recover. And there is some evidence that there's less severe nerve damage or permanent nerve damage than are seen in the optic nerve and spinal cord. Why that isn't entirely clear, but work that we've done here suggests that the level of expression of the aquaporin 4 protein and the presence of what we call aggregates of aquaporin 4 is greater in the optic nerve and spinal cord, which may make those tissues more prone to severe damage than other parts of the brain. I don't think that's necessarily the only explanation why the optic nerve and spinal cord are more frequently and more severely targeted, but I think it may be part of the explanation.
It's interesting. I think historically when we think of NMO, we don't really think of the brain involvement, and it's important to note, not only for patients, but I think for healthcare providers, that is a possibility within the disease process. Speaking of the disease process, there was a question about progression within the disease. What extent do we see disease progression and disability due to disease progression, and how does it affect lifespan? How does a diagnosis of NMO or NMO spectrum disorder affect lifespan and disability progression? Dr. Pittock, do you think you could speak to that?
Yeah, sure. Well, I think first of all we have to remember that prior to the discovery of the water channel antibody, and prior to the recognition that this water channel antibody was associated with an evolving spectrum of disease that expanded beyond what typically was considered NMO, which is basically involvement of both the optic nerve and the spinal cord. We therefore are seeing, to some extent, less severe disease at the current time, and also remember that the discovery of the antibody is allowing a diagnosis to be made much earlier than in the past. So therefore, immunotherapies are being started much sooner. So we have to be very careful how we interpret natural history data from the pre-water channel antibody days to the current time. Brian and Dean Wingerchuk did kind of the seminal work on the kind of not only the diagnostic criteria but also the natural history of NMO in the pre-water channel antibody days, and at that time, NMO was really, or at least the core features were that you had to have had an optic neuritis and a transverse myelitis, and oftentimes those patients hadn't been treated early, and so disability was quite severe, and approximately 50% of patients were wheelchair bound within 5 years. A significant proportion of patients had developed respiratory failure in the setting of high cervical cord lesions, and a high percentage of patients had significant visual morbidity. Currently, however, things are looking much better. If you look at work that's been done in France and also work from our group, the outcomes now are much improved. So that if patients are diagnosed early and start on immunosuppression therapies, the likelihood of needing a wheelchair after 10 years is probably less than 10%. So I think the natural history obviously it has been changed in the sense because patients are being treated earlier. So this really emphasizes the importance of attack prevention in this disease. If you stop attacks, it would appear that you generally will stop development of disability. So again, as Brian had pointed out before, if a patient comes in with a symptom that potentially could fit within an NMO spectrum, it's important to test the antibody, and if it's positive, it's important to initiate immunosuppression early. In regards to the issue of whether there's progression of disease, Dean Wingerchuk has done work on this and found that the progressive phase of illness, in other words, kind of similar to what we see in secondary progressive MS, tends not to occur in NMO. However, I think we need to be careful making definitive assumptions, and I do think that there may be some patients that do have some progression, in other words, worsening disability in between acute attacks. And of course, we still need to know whether or not that is related to subclinical or low-grade activity of inflammation, or is there indeed some type of a neurodegenerative process occurring? I think generally it is not the case, but it's not possible to make a definitive statement. And I've certainly seen some patients where there seems to be some progression over a period of time in between attacks, but it's certainly not in most cases. So much more work needs to be done on that. But it's important to remember that in MS, most disability really accrues as part of the secondary progressive phase of the illness, not as part of the acute attacks, whereas in NMO, it's the opposite.
Thank you. That does clear some things up in terms of the differences there. There was a question that I'll direct to Dr. Weinschenker about pediatric NMO and the prevalence of NMO in kids versus adults. And is there an estimated age when more diagnoses of NMO occur, or is it spread throughout the lifespan? And are there any suspected outside triggers or environmental influences on NMO?
Well, it seems like the occurrence of NMO is what we call bimodal. In other words, there's two groups. The biggest group are women who are late middle age. But there is a second group of patients, perhaps less commonly in the aquaporin 4 antibody positive group, but certainly quite a number who are aquaporin 4 positive who are children. And I think it can occur in any age in children. We've seen patients at Mayo Clinic that are as young as 2 with neuromyelitis optica, so it can occur at any age. In terms of whether there's environmental factors that trigger this disease, a number have been reported, including in different parts of the world, diseases like tuberculosis. But, I would say the only risk factor that I'd feel comfortable at identifying is having other autoimmune conditions. We know patients who have conditions like lupus and Sjogren's seem to be at greater risk. There seems to be a tendency for these kind of autoimmune diseases to cluster. I would say any other environmental risk factor is arguable. Infections seem to trigger attacks of the disease, but common infections like colds and flus, but I think that's a different thing than actually leading to the disease. They more trigger attacks, but many people have attacks with no apparent trigger at all.
You spoke about like paired autoimmune diseases. Do you see many diagnoses of NMO after in the setting of a diagnosis of lupus or Sjogren's, or do you normally see those other rheumatologic diseases diagnosed after a diagnosis of NMO?
Well, more commonly we see it before, but of course there's a certain biases that if you followed, there's usually more time before the diagnosis than after the diagnosis that you followed patients. I've seen it both ways, that patients first have neuromyelitis optica and then they develop other symptoms of other autoimmune conditions like lupus, but more commonly they have a history of, say, 10 years ago having lupus or myasthenia gravis. Often that condition is in remission, not even a clinical issue, and then they develop symptoms of neuromyelitis optica. That would be the more common situation.
Interesting. There's another question that kind of pertains to disease pathology that I think is we could speak a lot to in the setting of the research right now. But could another disease pathology or antibody be involved in NMO spectrum cases if a patient is negative for NMO IgG? Dr. Pittock, could you speak to that?
Well, I think the answer is absolutely yes. We know that NMO and myasthenia gravis have quite significant similarities. Both are antibody-mediated diseases. Both have an association with thymic tumors. Both can coexist. We know that in patients with NMO, for example, about 13% will have acetylcholine receptor binding antibodies, and 2% of NMO patients will have myasthenia gravis. And as Brian says, that usually occurs first. And we know that in myasthenia gravis that there's a percent of patients that have myasthenia that can have a clinical phenotype that's quite similar, but have antibodies that target the MuSK receptor, and now there's increasing evidence that even patients that are MuSK antibody and acetylcholine receptor binding antibody negative, that those patients can have antibodies targeting an array of proteins that are involved in the synapse at the neuromuscular junction. I think in terms of NMO, an antibody that has come to the fore recently is the Myelin oligodendrocyte glycoprotein antibody. This had received a lot of attention in the past in the old MS literature, but unfortunately at that time what they were using was ELISAs that were quite non-specific, and a lot of people kind of dropped the ball on MOG because the ELISA assay that was being used was identifying the antibodies to this target, which is a very sticky target in patients that had no MS or in fact were normal. But more recently, if you just look at antibodies that are targeting the extracellular epitopes, in other words, the parts of the MOG that are on the outside of the cell that are available to binding by the antibody, it appears that this antibody is a biomarker for patients that have symptoms and signs that can look similar to NMO. There are some subtle differences, but again, it's very early days. But I suspect that this antibody will be helpful in patients that have a phenotype that looks like NMO, but actually will have a different. The target of the immune system will be different. And I think as we move forward, we will also begin to find novel antibody targets in patients that have recurrent optic neuritis. If you take patients that have recurrent optic neuritis, for example, about 80% of those patients do not have a biomarker, do not have an antibody that's targeting a specific target, but they are immunotherapy responsive disease, and so those presumably will have an antibody that has yet to be discovered. So I think the field is exciting. I mean, obviously we're in the era of discovery of pathogenic biomarkers or antibodies, and so I think we will see antibodies coming out in the next decade that will help us diagnostically and potentially allow us to individualize how we approach treatment of patients in the future.
Yes, thank you, Dr. Pittock. Dr. Weinschenker, do you have anything to add to that?
No, I think that was an excellent summary.
Yes, it's very eye-opening, the new things that are coming up in terms of the immune system and antibody activity in these kinds of diseases. Switching gears a little bit for the second part of the podcast, there were a few questions that came up about specific therapies that are used within NMO to treat attacks and to prevent attacks. And Dr. Weinschenker, could you give us a little bit of an overview up front about immunosuppression, why that's used in NMO, and what kind of drugs are actively being used, and what kind of drugs are in the pipeline to be used in NMO and NMO spectrum disorders? Okay.
There are two types of treatment. One is to treat an acute attack when an acute attack comes on. There the goal is, of course, to salvage function, because usually patients are coming in with paralysis or blindness, and the goal is to help them recover as quickly as possible. Now, even without treatment, attacks tend to improve or recover, but it's very common in NMO that recovery is not ideal, and in some cases may be minimal. So it's important to treat with anti-inflammatory treatments. The standard would be intravenous corticosteroids. Typical drug that would be used would be methylprednisolone given intravenously over the course of 5 days. Very commonly effective, but there would probably be somewhere between 30 to 50% of patients who would either have an inadequate or minimal response. And in that group of patients, my own feeling is that the best established treatment is plasma exchange. which needs to be performed in specialized centers, but is a relatively safe procedure. It quite often will need a central line to be inserted, but the procedures itself are fairly safe, and there do seem to be other alternatives. There's some evidence that IVIG may also work in this situation, but much less evidence. The most important thing in the long term for patients with neuromyelitis optica is attack prevention. And we use a variety of medications that suppress the immune system. Historically, the first drugs that were reported were prednisone and a medication called azathioprine, sometimes sold under the name Imuran. Taken together, these medications are very effective. Usually it takes about 6 months for azathioprine to take effect, so patients would be kept on prednisone, which works very quickly, for 6 months, and then the azathioprine tapered. There are other options. There's a medication called mycophenolate mofetil, often sold as Cellcept or Myfortic, which is also quite effective, more or less equally effective as azathioprine. About a decade or perhaps a little longer ago, Dr. Bruce Cree in San Francisco piloted the use of a medication called Rituximab, which is a selective antibody that depletes B cells, which are the antibody-producing cells. And this is proven to be quite an effective treatment, even in some patients who don't respond to azathioprine. We still don't know whether it's overall superior, because typically it's tried in patients who fail other treatments, but it can be remarkably effective even in patients who are not doing very well. And it works fairly quickly. Within 1 month, there's complete depletion of B cells. It needs redosing roughly every 6 months. So those would be the mainstays of treatment. We have other more potent drugs, and then there are some drugs which are, I would call, experimental and are currently in clinical trials. And I don't know whether you want me to discuss them, Sam, but I would say they're not ones that should be standardly used at this time, but are quite promising.
Yeah, I think there are a few clinical trials, drug trials that are out now that are actively recruiting that I think a number of our NMO community have probably heard or read about. And I think we'll probably be asked to participate maybe at some point. And I think any insights that you or Dr. Pittock might have and things to consider when being approached about a drug trial of any sort, regardless of what the drug really is probably helpful to the community.
Okay, well, I'll start. And, I think patients should first consider their own benefits. I think that's always an important thing. But then there's, of course, the issue of we want to move ahead and get better, more specific, more effective drugs. And practically always when patients volunteer for clinical studies, part of the reason that they do so is the general wish to try to move knowledge forward in neuromyelitis optica, and without patient volunteers this is never possible. So the specifics that patients would want to know is often these studies are randomized, that is, patients are not given a choice as to which medication they take, and they would either get the experimental medication or they would be randomized to receive a control, and the control may be nothing, may be placebo, medication that's or either intravenous or as a pill that they don't know whether it's the active or just a inactive treatment, but maybe really nothing other than sugar or some substitute. So, that's a potential risk. Some studies randomize patients to get either the active treatment or the experimental treatment or another active treatment. And in some studies, all patients may be allowed to have some type of standard treatment, and on top of that are randomized to receive one or the other. And as you can imagine, there may be different levels of risk. Probably the greatest risk would be if you have a potential of not being randomized to active treatment. In some studies, 3/4 of the patients would be given the active drug and 1/4 not. Other studies, it might be 50-50. So those would be considerations. Obviously, you'd want to take into account the known side effects of the drug, because all drugs have potential side effects, and there's risk of being randomized to the active drug as well. And patients probably want to consider what is the background information that suggests that that drug might be effective, both the rationale and whether there's been previous experience with that medication. So I think those would be the key things that patients would want to consider when being approached about participating in a clinical trial.
Yes, I think those are all very wise recommendations. Dr. Pittock, do you have anything to add to that?
Yeah, no, I agree entirely with what Brian has said. I think first of all the three drugs that are going to randomize a phase 3 trial, I think they make a lot of sense. They all have somewhat different mechanisms of action. There's reasonably good preliminary data in at least for 2 of the drugs. And certainly for the MEDI551 drug, which is an anti-CD19 drug, you can certainly draw conclusions from Rituximab that this drug is going to be efficacious. So I think there's a lot of good reason behind the 3 drug trials. I do think that certainly from my perspective, if you had a patient that really is failing or continue to having attacks despite standard of care, then that patient is probably someone who at least will be looking for alternatives. And the other thing I think to look at, in addition to kind of discussing the specifics of each drug trial with the physician who's potentially enrolling patients, is to look at what happens after you come out of the drug trial, or if you did have an attack. And many of these drug trials now are offering patients in an open label fashion the opportunity of getting the drug for some years, and so that also might be potentially attractive to some patients. But hopefully, it's also important to note that this is a good time for an orphan-like disease where we have, essentially 3 randomized controlled trials now in a disease that was, to a large extent ignored, and certainly the concept of having randomized controlled trials in such a disease was not even on the horizon, some years ago. So I think it's exciting times, and I think patients at least have a lot of things to consider, and they have options, and they just have to make the best decision for themselves, as Brian has pointed out.
Mm-hmm. Communication is very important between the research team and the treating team and the patient who really is the focus of the research. So I wholeheartedly agree with what both of you say. I agree with that based on my experience in clinical research working with patients. So I appreciate that. There is one specific question that was asked about therapies that I think would be a good thing to touch on for a little bit. You all, Dr. Weinsteger, you spoke about the different types of immunosuppressants that are being used now to ward off attacks in NMO. There's one patient who asked about being steroid dependent. When they try to wean off prednisone that's paired with Cellcept, they have a relapse. And it has happened many times with them. And they've been on prednisone for 6 years in addition to their Cellcept. And I have anecdotally heard from a number of patients that this is an issue with them being steroid dependent along with a long-term immunosuppressant. this something that's concerning to you as a physician, and how would you deal with this?
Yeah, I've heard this many times too from patients. I think it's a common phenomena in neuromyelitis optica. Prednisone long-term, especially in high dose, can have significant toxicity. Weight gain, cataracts, diabetes, high blood pressure, many osteoporosis, many undesirable side effects. So our goal is really to try to keep the dose as low as possible. In some patients, we seem to successfully be able to get them off steroids altogether when they're on a medication like azathioprine or mycophenolate mofetil. But some patients, they need some dose of prednisone, typically a small dose, even 10 to 20 milligrams daily or every other day, may be absolutely essential to keep them free of attacks. And I would say in general, if we can keep the dose under 20 milligrams a day, as well as take measures like monitoring bone density and treating for osteoporosis and for prevention of osteoporosis, the potential side effects may be acceptable, especially considering the disease that we're dealing with, the neuromyelitis optica, and the importance of keeping patients free from attacks. I suppose if there were a situation where we couldn't get the dose under 20 milligrams a day, or patients were continuing to have relapses, even non-steroids, then that's a situation where you might want to consider Rituximab or another treatment. Typically, patients on Rituximab don't need any other immunotherapy. They don't need steroids. At least that's usually been my experience. And we can treat them with Rituximab alone. So if they haven't had Rituximab, I think that's a good option in that situation.
Thank you. That was very informative about, I think, an issue that a number of patients have, like you said. We're in the last few minutes of the podcast here, and I wanted to give both of you, Dr. Weinschenker and Dr. Pittock, a chance to kind of wrap up your thoughts on where we are now with NMO spectrum disorder, and like we've been talking about the pathology, our understanding of the pathology, and novel therapies that are coming out, and kind of what you see for the future, and where you as researchers and clinicians are working to get us to with your colleagues. Dr. Pittock, would you like to start with your final thoughts?
Well, I think it's a very exciting time for this disease. I think the advances have been significant in the last 10 years. I think they all stem from the original work that Brian and Vanda did, and the discovery of this antibody. It's really the first biomarker that's sensitive and specific for any form of inflammatory demyelination disease. I think we've certainly dramatically improved our understanding of what's happening from an immunopathologic perspective. And those advances, I think, have led to the current status of drug trials, where we have three very exciting medications that are going to enter into trial, and hopefully we will get very important information in terms of whether they work and whether they're and hopefully in the future whether they're better than what we're currently using. I think there's still significant implications for patients. Earlier diagnosis, initiation of treatment earlier will reduce disability, and I think will significantly improve the long-term outcome for these patients. We still have a lot to learn. I think it's very important that we not drop the ball and assume that we know all. We still really need to know a lot more as to what exactly happens when the antibody binds to its target. I think there's a lot that still needs to be learned, and knowledge of those early events potentially will result in getting better drugs that are cleaner and have less side effects. Our ultimate goal is to stop attacks with drugs that don't have any side effects, and that's a big goal, but I think it's doable, and I think we just have to enthuse the not only industry but also patients to continue to assist us by becoming involved in drug studies or trials, but also trying to get dollars to assist us in finding the answers.
Thank you, Dr. Pittock. And final thoughts from you, Dr. Weinschenker?
Well, I think Sean gave a very nice summary of the current state of things. From a disease that we thought was 1 in a million or less, we're learning it's about 1 in every 25,000 people, which that's still an uncommon disease, but not so rare when put in the context of other neurologic diseases. I think on the good side of it being more common is that perhaps it's not quite as uniformly severe as we used to think, and we're recognizing this broader spectrum, but it is clear that we can now specifically identify patients with neuromyelitis optica, and we've learned that we must not use standard MS treatments, although not all have been tried. A number of them have either been ineffective or seem to actually make the disease worse. So the treatments that we use standardly, although they're not new and not specific, are very good if they can be applied early in the disease. But we've heard about a lot of new treatments that are coming out in clinical trials. Unfortunately, I don't think any of these will be curative. It'll still be a matter of having to continue on treatments. But knowing the target of the disease now in aquaporin-4 antibodies, I think it is at least conceivable that strategies could be brought forward in the future that could lead to a more permanent cure or very highly specific treatment. Still, I think, visionary, and I don't think we can say for certainty if we're going to be there, but it is promising, and I think the future does look very promising for treatment to this condition.
Great. Thank you both. Thank you, Dr. Pittock and Dr. Weinschenker, for sharing your time and expertise today with our community. Very helpful, very good questions asked by the community. Couldn't get to all of them today, but really appreciate all of the interest and effort from the community to be a part of this series. And thanks to Chugai Pharmaceuticals for their support of the Ask the Expert podcast series. I hope everybody has a great weekend, and everybody keep an eye out for next month's Ask the Expert podcast announcement. Thanks, and again, everybody have a great weekend.
Thank you.
Thank you.